Thank you, Sripriya, and thank you everyone for joining us for this program. I think this is a season 100, right, Sripriya? This is a 100th program that Tips Eco is conducting. So welcome you all for the program, and thank you so much for your interest in learning palliative care. I think we'll be having 20 sessions altogether for this program. Today we'll be starting with the introductory part of it. Many of you might be already working in palliative care or you already know palliative care, but this is mainly meant to come into the kind of having a discussion and exchange the concept of palliative care among ourselves. So today we have as our faculty, Shripriya, Dr. Raj joined already?
Yes, he's joined, just joined.
So today we have Dr. Raj as our faculty. So many of you might be knowing him. So he is the chairman, founder chairman of Pallium India, and he is always referred to as father of palliative medicine in India because of his contributions to the specialty in the country. And he was been awarded with Padma Shri in 2018, and he has played a significant role in the NDPS amendment in 2014. And I think much more to explain, but I think I should stop there. And he is an amazing, amazing teacher and a wonderful doctor. Sir, over to you for the introductory session, and welcome you for the program.
Thank you, Sri. Thank you for saying those nice things about me. I wish I had known that you were going to say all that. I would have logged in a few minutes earlier. I missed much of it. Hello, everybody.
Hello, sir.
Hello, sir.
Thank you.
Hi,
but can that hello come with smileys? Yes, very good, very good. That hey, Sri, did you notice the screen has brightened up all of a sudden with so many smiles? There are one or two phases where the muscle rigidity is still considerable. Well, I suppose we'll have to live with that. Hi, everybody. So again,
Hi,
Sri,
sir.
is there a case presentation?
Sir, we'll be doing one presentation from our side as an introductory.
Okay, as usual.
But we don't need much time because we just need to present the form.
That's okay. Sri, do you want to tell me a bit about the spread of the participants between specialties, between countries, between states, anything of that sort?
I think Sripriya, that's you.
Two Sris, so the confusion. Yes, sir. So we have mostly participants from India and one participant from Germany. Unfortunately, the Thailand participant couldn't join us for the session. Regarding the professional aspects, we have MDs from like anesthesia, specialized in anesthesia, general medicine, and regarding work profile, we have participants from public and private sector both, sir. It's a ratio of like.
Okay, very good. Thank you. So what I propose to do, ladies and gentlemen, during the introductory session is to try to say what palliative care is. That concept is changing. So we may have to talk about the evolution of the concept. What it seems to be now, I don't know what it's going to be tomorrow. Then I'll say what its components are and how exactly it is positioned in the healthcare system. What do we see as its position of healthcare system today and tomorrow? I wish we had more time. I would have loved to find out why you are here joining this course. The reasons must be several. Typically, in a group of this kind, at least 1/4 would be people with lived experiences in your own family with serious illnesses. Those people would have gone through a lot of suffering. It is possible that as we proceed with the course, many of the things that we say may evoke painful memories in those people. I'm sorry if some of the things that we talk therefore hurt some of you, but maybe, though it is painful, reliving those experiences also helps in the healing process, in coming to terms with the memories of suffering and with the loss, if that is the case. Many others would be here just because you like helping others, you want to do a bit more with your profession than you have been doing so far, maybe by fifth year, something like that. Uh, Sri, so after about 1/4 of my presentation, I would request you to show that total pain video, Smriti. I hope you will be ready with it.
Yes, sir.
With that, I am starting to share my screen. As I said earlier, the concept of palliative care has evolved with time. Do you know who is the founder of the hospice movement in the globe? Who founded the concept as a whole in the world? Please put up your answer in the chat box. That's the name. Dame Cicely Saunders, who started her as a career as a nurse, then became a palliative care social worker. And interestingly, doctors, she tried to talk about the need for relieving suffering in seriously ill people. And if nurses and social workers talk about it, would doctors listen? Finally, a senior doctor told Cicely, go and read medicine. Unless you are a doctor, no doctor will listen to you. So in her 30s, she became a medical student, qualified as a doctor, and she founded the hospice movement in the world. But when she did that, palliative care was really for people with incurable diseases. Cicely Saunders was specifically aiming at cancer. And in 1986, the World Health Organization defined palliative care. The paper was published only in 1990. But at that time, palliative care was defined, many words, for people whose disease was no longer responsive to curative treatment. And I remember that in a cancer hospital that I knew of at that time, before the referring doctor had to certify on the case sheet that this patient has no more avenues for curative treatment, and only then palliative care people were allowed to see this. The consequence was that a lot of people whose disease was not clearly incurable, where there was a suspicion, were denied palliative care. And recognizing this, in 2002, the World Health Organization redefined palliative care. They redefined palliative care as an approach to improve quality of life for people with life-threatening illness. What does life-threatening illness mean to you? Something that limits the lifespan? Actually, when this definition was brought out, this was the way in which most people took it. That is, when lifespan is limited, that means practically in a terminal illness. That's the meaning that very often was ascribed to it. Ladies and gentlemen, let me ask you, if somebody has a paraplegia, you know what happens in our country. Our roads are not accessible, our public places are not accessible. That person, if rich, is still confined to a home, and if poor, is confined to one room, confined to four walls. His life is threatened by four walls. Should he not have relief from suffering? So given this definition, that the revised definition, it has been recognized, has holes in it. And recognizing this, World Health Organization a few years back asked an international organization to submit a revised definition. Unfortunately, another international organization said that was not acceptable and therefore it did not become official. But in 2018, Lancet Commission. Do you know about Lancet Commissions? You all know about the Lancet, right? One of the three foremost international medical journals. The Lancet periodically appoints commissions to go into one particular area of healthcare and submit their reports, rather globally reputed reports. So there was a Lancet Commission on the global access to pain relief and palliative care. Global access to pain relief and palliative care, if you Google it, it's available for free download. They brought up this concept, slightly modified concept, where palliative care is meant as prevention and treatment of serious health-related suffering. Prevention and management of treatment of serious health-related suffering. Many of you are young doctors. One or two generations subsequent to me. Two generations back, when I studied medicine, practically we were taught about diseases. All our basic sciences were meant to understand diseases and to medicines. Then there was a little bit about preventive medicine, which was still about diseases. And then the rest was all diagnosis and treatment. There was nothing about suffering. Nothing at all. There was nothing in the curriculum, and by what we saw in the wards, we were schooled to ignore suffering and to walk away from suffering, because seeing the suffering makes us feel important to do anything about it. So I learned to walk away from suffering. And unfortunately, 2 generations later, many of you have just completed medical education, still studying only diseases, not treatments. Palliative care is that missing chapter of medicine which takes into consideration prevention and treatment of serious health-related suffering, along with treatment of the disease, not after. That's the important thing, along with treatment of the diseases. Shall I pause there so that anybody can offer a comment or a question? You are welcome to unmute and speak. Or I put it upon the chat box. Any comments? Yes, Dr. Dheeraj.
I just had a query. How is palliative care preventive? Are we not dealing with the condition after it has occurred?
Dr. Dheeraj, you have a comment? Sri, can you
Yeah,
see
I have
Dr.
a question.
Dheeraj, you are,
Yes, sir.
are
Dr.
you
Dheeraj is
muted? I can't
talking.
hear you.
No,
Yeah.
he just asked a question. How can palliative care be preventive?
Sri, are
Sir,
you
did you
able
hear
to
that?
hear Dheeraj?
Yeah, sorry,
Sir,
I want
sir.
to ask a different question.
Sir,
Sridevi?
are you able to hear us, sir?
Priya?
Sir,
Are
Dheeraj,
you able to
Dr.
hear
Dheeraj.
me?
Yes, sir, you are audible, and Dr. Dheeraj is also audible, but his question is different, I believe.
Sri Priya, you are not able to hear me?
You are audible, sir.
What's wrong?
Sir, we can hear you, sir, but you can't hear us.
How about now? Can you speak? I can't hear you.
Sir, can you hear us? We were able to hear you.
Finally, I am unable to hear you. Maybe my earphone was malfunctioning. Let me try to connect it once again.
Sure.
Sri, speak up, please.
Okay.
Can you still hear me? Okay.
Yeah.
Apologies.
Sir, Dr. Dheeraj was asking the question that how can palliative care be preventive?
Dheeraj, where are you from, Dheeraj?
Sorry, my question was different. That question was asked by someone else.
Sorry.
I'm working in Chhattisgarh in the Sarguja district. And my question is related to that third definition that Lancet has published, that prevention and treatment of serious health related suffering. Then is it not that all the treatment we are doing is a palliative treatment?
All treatments? No, many of your treatment would be curative, wouldn't it be? When you are treating an infectious disease, when you are providing chemotherapy to a child with acute lymphatic leukemia, you are providing curative treatments.
Yeah.
Why? But Dheeraj, I see another aspect of your question. You are saying, possibly meaning that by treating disease and curing diseases, you are relieving suffering. Accept it totally. But also remember that less than 1/3 of all the diseases that come to us are curable. 2/3 of all the diseases are incurable, including hypertension and diabetes. Okay, leave that alone. If I come to you with cancer, Dheeraj, and pain, you will cure me with treatment spread out over 9 months. Why should I suffer during those 9 months? Why should I suffer even for 1 hour if that suffering is preventable? So, Dheeraj, yes, curing disease is a noble task that doctors have the privilege to do. I value that. All I am saying is, along with that, health-related suffering should be seen and treated. Okay, Dheeraj? Am I making sense, Dheeraj?
Yeah.
What was the other question, Sri? I didn't
Sir,
see.
how can palliative care be preventive? According to the definition, there is
Okay.
prevention of suffering.
Prevention and treatment of suffering. Who asked that question? If I may get a name.
Sir, this is Dr. Satyajit Mishra, sir. I asked the question.
Satyajit, where are you from?
I am from AIMS Bhubaneswar, sir.
Hi. Satyajit,
Yes.
if you have a patient with a spinal cord injury, you know that in our country, the majority of people who get traumatic paraplegia eventually get pressure sores and repeated urinary infections. They're pretty much the routine. Both are preventable and totally avoidable. If we have a patient with traumatic paraplegia, the preventive part of palliative care should go. I'm not saying that the patient should be sent to the palliative care clinic. And we'll later on talk about how palliative care can be integrated into curative treatment. The treating team makes sure that the position is changed, this is prevented. Or take another situation. If somebody has a hip replacement or a knee replacement, the surgery will be useless unless there is concurrent physiotherapy, which will prevent disability, prevent contractures, and that would be a palliative measure. So, anticipating possible suffering and treating them would be part of preventive palliative care. It is poorly developed, Satyajit. It's up to you now to develop it to its full potential. I mean, your generation.
Thank you, sir.
Thank you for your questions, and I'll move on.
Can I ask one question?
Yes, please.
Sir, any post-operative phase, can it be considered as palliative care?
Sorry, Shilpa.
Yes.
Shilpa, later on, I'll talk about integration of palliative care into healthcare. And Shilpa, I think your question will be answered at that time.
Okay.
Talking about suffering, you must let me spend a few minutes on the current status of health-related suffering in our country. This is 2013 National Crime Records Bureau. The number of reported successful attempts at suicide, people who kill themselves, more than 26,000 people. Every year it is more than 26,000 people. And you know the actual numbers are much higher, many not being reported at all. Just imagine, ladies and gentlemen, for every one of them, how many tens or dozens will be attempting and failing? And for every person who attempts it, how many people will be living wishing they had the courage to attempt it? So this is the truth in our country, the extent of suffering and management of pain. How do you assess access to pain relief? Leave alone all of palliative care, just pain relief. Difficult to measure. Indirectly, morphine consumption is usually taken as the index of access to pain relief or even access to palliative care. Now, we don't want to quote the statistics from USA or Canada, where there is a lot of non-medical and inappropriate use, but we take the example of Western European countries, UK, France, Germany, Netherlands. They all have more or less achieved a balance of access to pain relief without significant inappropriate or non-medical use. By the way, ladies and gentlemen, this presentation will be sent to you by Sridevi. Any presentation that we make here, you can have it. So, this is more or less considered optimal per capita. In the population, in milligrams, this is the per capita consumption in countries where pain is reasonably managed. But unfortunately, the global average is only this much. And see where India is. It is that bad. It is about 1 in 2,500 of what is optimal. Kerala, Sridevi and I go about bragging a lot that Kerala is a lot better. But Kerala, Sridevi and I have taken a decision not to brag anymore, because compare this with the global average or with what is considered ideal. So situation is pretty bad, ladies and gentlemen, and so I am glad that about 60 odd of you are here to change the face of healthcare in the country. Unfortunately, friends, sorry to keep adding bad news, healthcare access and quality is not reputed to be very good in our country. The countries marked in red are bad. not good at all. India is among them. And that's another thing that we need to improve. And especially the problem of end-of-life care is very, very unfortunate. You see this quotation that from Dr. Sankha Mitra, a Bengali oncologist, currently working abroad and spending all his salary on palliative care in West Bengal. His organization called East India Palliative Care. He says in India, the poor die in misery and neglect. The middle class die in misery of ignorance. They know that pain, they may have been able to access pain relief, but they don't even know that pain can be treated. The rich die in misery on ventilators like this. No one gets a pain-free and dignified. Sorry, I'm painting a very gray, dark picture. But this is for us to change. Let us as well face it. In 2015, when the Economist Intelligence Bureau and Lane Foundation together assessed the quality of death, India came amongst the worst 15. In just a few months back, in December 2021, the same organization, but a different modality and different set of indicators, reclassified quality of end-of-life care. And India is still among the among the worst 25%. So not generally about palliative care, specifically about end-of-life care, specifically for the situation that Dr. Sankha Mitra is crying about. This is also a problem. So, ladies and gentlemen, I have pointed out that generally access to pain relief is bad. The suffering is as measured by people taking their own lives is bad. Quality of health as a whole is bad, and quality of end-of-life care is bad. Sorry to paint that gray picture, but we may as well face the reality. And the reality is also that more than 4% of our population are subject to catastrophic health expenditure every year. Every year. You know them. You have seen them in the hospital corridors. They are there. And very recently, just a few months back again, 21 December, these three oncologists did a study in 3 different states in India and found that specifically for cancer, 54% of patients are subject to catastrophic health expenditure. Okay, this is the background on which our work now starts. We are going to change it. When I say we, all of us together. Dr. Shilpa, Dr. Bikram Bera, Dr. Grace George, Dr. John C. James. I'm just reading out some names that I see right in front of me. We together are going to change it. One little bit at a time. Let us not underestimate the power of one. If you take away the needless suffering of 10 people, it will eventually turn out to be a geometric progression. Because from Dr. Bikram Bera, several others are going to see the change and they are going to follow you. But I have been talking about pain control mostly, morphine consumption, treatment of pain. And those of you who remember, or of the kind who remember those lessons from middle school, will remember that only a small part of an iceberg is visible below the surface. How much? 1819 something. When the patient comes to you, what you notice is the pain and the breathlessness. But when you treat it, you uncover more. Like this man, in agonizing pain, had relief with the kind of opioid titration that Dr. Sridevi and team do. When we find somebody in excruciating pain, we don't start oral morphine and wait for 2 days for relief. They put in a butterfly needle and start giving small boluses of morphine, or if we are feeling particularly rich, something quicker, uh, intravenous fentanyl. This can also be given subcutaneously. So when we do this, within an hour, we know how much of injectable medicine is necessary to give the person pain relief. And the effect is remarkable. The person sits up, smiles, and then compliance to your treatment is much, much better. Because when Dr. Rishi Mero takes away the pain in 1 hour, the patient develops great trust in you. Moreover, it's also relief of suffering is good, isn't it? Why should the person suffer for another day when you start an oral medicine? So when somebody comes with what is visible, naturally we have to treat what is visible, what is in the surface. And for treating pain, after that quick initial titration, you proceed to put them on oral medication. We put in treat, maybe start oral medication, usually by the WHO ladder, in where in unless they are already coming with severe pain, you may go straight to step 3. Otherwise, in the first step, you take a non-opioid and an adjuvant if necessary. You may add a weak opioid like tramadol later. And if that is not enough, you take away the weak opioid and continue with a strong opioid. The non-opioid and adjuvant are continued all through. Maaf kijiyega, I'm not going into the details. Not today. There are going to be sessions on pain management in detail later. So with this man, after the initial titration, we'll put him on oral medication and control his pain. And when the initial problem, the surface work is over, then you discover all the other issues, the psychosocial issues related to sexuality. I mean, what does a man feel like when he has had an amputation of the penis? What does a woman feel like when she has had a mastectomy? What people say is, now that that hysterectomy has done, doctor, I don't feel like a woman anymore. What that person needs is somebody to listen to this, to make sure that the spouse, the husband understands this, so that with demonstration of affection, he can demonstrate that you are not unattractive to me. Of course not. I love you. What I am saying is, unless you dive into the cold water, explore the explore with conversations, you don't unearth the problems, including damaged relationships, spiritual issues. What's the point of me being alive? I might as well be dead. Or why did God desert me? So these are the depth work in palliative care. Guess what is the easier thing? Of course, as you can guess, treating what is above the surface is easy. Diving down there and finding these are more difficult, but those are the things that we'll talk about in our course. Sri, can you please show that video? I want to show you a video demonstrating what we call total pain, not what we call. Cicely Saunders called it total pain, the conglomeration of physical, social, psychological, and spiritual aspects of pain. The talk is given by Smriti Rana. I suppose she'll be doing a session for you later. Smriti is a psychologist by profession and manages our strategic partnerships and policy division. Yes, Sri.
In palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by this stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own, and he asked him, he said, "What's your biggest concern right now? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own. And this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these 2 children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. Still 6, he said. He was then shown the documents, and he was told, "It is done. Your children will not be fishermen." The transformation on that man's face was magical. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" 1. He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing.
So, friends, you saw the video where morphine could take some of the pain away, but we all know what a power the mind has over the body. That man's pain needed somebody bothering to sit down with him and finding out what are your problems. Finding out what was bothering his soul and trying to find a solution. We cannot solve all problems. Even when we cannot solve all problems, we don't desert them. Total pain is the integration of physical, social, emotional, and spiritual aspects of pain. Any comments about that video, or can I move on? You're all looking very thoughtful. Dr. Mirazul, Aganksha, any comments? Any thoughts?
So we have some doubt about it, but I'm waiting for the next class to come. When you are classifying about the degree of pain, that portion I didn't actually understood. So I thought we will come to know later, I think. So
I think that will be better. Yes.
Dr. Anuba, you have a question. There is a hand. Dr. Anuba has raised her hand.
Who? I don't see.
You already spoke, Dr. Anuba.
Okay.
The mentioned and it's very powerful in a way that emotional pain also being a part.
Dr. Anupa, I think we are losing you in between.
Anubha, will you please switch off your video and speak, because your voice was not coming through.
Am I audible?
I think that's a problem with the microphone. Maybe you can type in the chat so that we can read it out for you.
Better put your video back on. It's good to see at least your face. And then we'll, please type up. You're not audible. Anybody, any other thoughts about the video or the concept of total pain? The importance of emotional pain is in total pain. Yes. Yes. You were saying that you feel that from the video, right? Anubha? Yes. Thank you. I think I'll go back to my presentation and continue with the description of palliative care. I see that we have already crossed 40 minutes. Have you heard about the Astana Declaration? Astana was the capital of Kazakhstan. In 2018, world nations, including India, got together there and came out with this declaration of universal health coverage, saying that healthcare should reach people where they are, when they need it. Where they are. See, that man that Smriti was talking about in her video, that man was in his home. At that stage of the illness, a poor villager cannot get to the hospital, especially when the doctors have said we can't cure you. Tomorrow, when you start your palliative care work, Roshni or Aditi, you may not be able to get to the patient's home yet. Tomorrow, I believe that should be our goal. If they can't come to us, we should go to them. That's what Astana Declaration anyway. The statement is obvious. Healthcare should reach people where they are when they need it. And health for all has to be health with all. The community has to be engaged in a partnership with us. That man in that hut whom Smriti was talking about would not have got to us at all. We wouldn't have got to them if volunteers in the community had not intervened and supported the person. So the community involvement and include people in the designing and controlling health systems is what the Asthana Declaration says. So, that's what we try to do. We started, all our work started with just on an outpatient clinic and one team going out on home visits, both together. Later, we added an inpatient unit. That came later. This man again, he needed care desperately. The hospital would not have found it. What was wrong with him that he had this nasty fungating ulcer there and he didn't want to be seen by anybody. He shut himself up inside. And when we fashioned a dressing, just a piece of gauze, that the family themselves could wrap around it, he looked at himself in the mirror. He was not that ugly anymore. He started coming out of the house and sitting outside, enjoying a little more of the world than he was used to be. And for that, we needed to reach him. Someday, I hope you all will be able to reach people like that in their homes. Now, I come to one more point. Earlier, when you asked about preventive measures, etc., I said we'll talk about integration later. In the first description of palliative care, I said prevention and treatment of serious health-related suffering. How do we do that? Ideally, we should be integrating palliative care into health systems at all levels. Most of you are clinicians. There are anesthesiologists, oncologists, internal medicine people. I do not expect all of you to give up your chosen specialty and specialize in palliative care alone. For the majority, what I would hope for is that you will all integrate the principles of palliative care into your work. This is what the World Health Assembly is the decision-making body of the World Health Organization. It meets every 2 years. And in 2014, they came out with this resolution asking all member countries to integrate palliative care into health systems at all levels, primary, secondary, and tertiary. I see that we have Sangwari, somebody from Sangwari here. I know that you do it in the villages at the level of the primary care. But also, when you have a patient coming to your hospital, which includes an intensive care unit, wherever you are working, whether it's in the patient's home, in the taluk hospital, or in a tertiary care center, integrate palliative care into your work. What does that mean? That means, doctor, if I am your patient and I am coming to you, Dr. Satyajit, where are you from, if I may ask you?
Sir, I'm from Bhubaneswar, sir.
Dr.
Orissa.
Satyajit, if I am coming to Bhubaneswar as your patient someday, inevitably I also will be. Everybody needs healthcare at some point in the life. Doctor, if I come to you, I hope you will see not only a microorganism or a tumor. I hope you will see the suffering in my eyes. I hope you all will not ignore the tears rolling down my cheek. If I am scared, maybe you will lay a hand on my hand and say, I will look after you. I see you are suffering. You can imagine what extent of relief it will come to me when I know that Dr. Aganksha cares for me, cares for my welfare in a strange environment of a hospital where I Everybody is impersonal. Knowing that somebody cares is great. That's also integration of palliative care. When along with the antibiotic you are prescribing, you also prescribe to me a rational analgesic. You are integrating palliative care into your work. When you do not ignore my breathlessness, and in addition to giving whatever bronchodilator you are giving, you also tell me, I am going to show you how to try to breathe slowly. Try not to breathe sudden gasping breaths like that, but try to breathe slowly in, and you will feel better. That will be integration of palliative care. And that palliative care eventually will be delivered by this system. The image is created by, it is nothing official about it, but this is part of what Astana Declaration advises, and this is what the World Health Assembly advises. Engage the community. That forms the basis. They know where the patients are. They know the circumstances. They know the social issues. They know the emotional issues more than us. And everybody, the GP, the internal medicine person, the oncologist, the anesthetist, the ophthalmologist, the ENT surgeon, everybody understands a little bit of palliative care and integrates it into your work. Is that possible? It's going to be possible. Maybe it will be too late for me. From 2019, medical students who join medical college from 2019 have palliative care included in the curriculum. Dr. Sridevi and colleagues are busily engaged in creating a proper teaching module which will be openly available for any faculty member anywhere in the country. Then that is going to happen, and I hope each one of you will be able to do a bit of palliative care along with whatever else you are doing. Dr. Rajit Thomas, and from MKM Hospital. In your routine practice, whatever your specialty is, I hope you will put in a bit of symptom control and a bit of psychosocial support. Palliative care units will still be necessary. With your palliative care approach in the general OP, you may not be able to solve all their problems. You may find that one pain is difficult to control, or this person is very severely depressed. You may have to refer some of them to palliative care units, but that will be for the minority. The majority will be what you put in as you in your chosen specialty. Can I end with some good news? Dr. Dheeraj, don't look so depressed. I know I have painted a very bad picture, but there are good things happening around the corner. India created a national program for palliative care in 2012 so that any state government can get some money for palliative care by putting in the proper applications, and we have teams to help you access it for your every state. Not individual doctors, but the state government can access those funds. The rules governing opioids like morphine have been changed so that now it is easier to access morphine, fentanyl, methadone, etc. And the national health policy of Government of India now includes palliative care. You may not know this, but during 2020 and 2021, national level trainers in palliative care and then state level trainers have been trained already. Your state's national health mission now has state level trainers who are now supposed to teach the staff in family wellness centers the fundamentals of palliative care. That will be only the fundamentals, but that is still a great beginning. And as I said, MBBS curriculum now includes most parts of palliative care, and most recently, nursing curriculum also has included palliative care. So it's not all bad, though I painted a very grey picture in the beginning. Let us tap some bright colors over it, considering what the positive things that are likely to happen soon, for which all of us will be partners. I'll stop there. I'm happy to come back to any part of the presentation if there are questions. I see that before the next part of the session, we do have some time.
If you have any questions, you can either unmute or you can type in the chat. We have a few minutes for discussion. Yes, Dr. Shweta.
So you were talking about the morphine opioid consumption, right? As in, it is very, very minimalistic in our country. Is it? What is holding the country back? As in, regulatory norms are not allowing opioids to be prescribed when it is known that it can be beneficial, or where is the hesitancy coming in from?
Shweta, where are you from?
From this, Mumbai.
Okay. Maharashtra was much better off than the rest of the country in opioids. We'll have a separate session, one whole session on opioid access. But to answer your question now, things were much better in India. When I was a house surgeon, I could write a prescription and as a house surgeon, and the family could get the morphine injection from the pharmacy. What changed was the Narcotic Drugs and Psychotropic Substances Act of 1985, which was created to prevent abuse. Unfortunately, it could not prevent abuse, but it prevented completely medical use of morphine. So that for your generation, Shweta, the medicine was a stranger. As a practicing doctor, till I came into palliative care, I had not seen a tablet of morphine. But that has been changed, Shweta. In 2014, the law has been changed. But many state governments have not implemented the amendments. But things are changing. Things change slowly in our country, but things are changing.
So I would like to add a point to that. Maybe till 2019, undergraduate medical students were not really learning pain management. And then suddenly, after long years of practice, they are suddenly introduced to the pain management and the opioids. It takes some time for them to accept it, sir. Just adding on to what you said.
Totally true, Sri. It is there in the curriculum. Who is going to teach it? It's going to be taught possibly by doctors, teachers who believe that it is a dangerous thing which should not be used. It will take time. That's why Sridevi and team are creating that teaching modules. Sri, can we promise this group and that they are likely to have it all?
Yes, sir.
By the middle of 2022?
Yes, sir. That's a bit scary for me, but yes, I'll be doing that.
So you, ladies and gentlemen, you all will have to be pioneers, because how many centuries back, Rudolf Virchow said that physicians are the natural attorneys of the poor. For people who are suffering, there's going to be nobody else to speak for them except us. So it's not enough if we are good, kind, compassionate physicians. We we also need to speak out for them and be agents of change.
So there was a question on the post-operative patients in palliative care asked by a doctor. I hope that's answered, or if you want any more clarification, we
No,
can
I did
just.
not see the question.
I think one doctor unmuted and asked about.
What's the question? Can you read?
Is that doctor still there in this group? I understood it as what about patients with post-operative period and how palliative care plays a role. That's what I understood when she asked.
Okay, good. I sorry I missed it. So in our country, post-operative pain is ignored. Westerners, if they come here, they are shocked to find the pain. We take it for granted. Uh, the medical tourism is a big thing in India. And in a medical tourism conference in Delhi, the president of the international something medical tourism thing, he was an Israeli doctor, said, India, to come up with the health tourism, needs two things. One, it needs better roads. Secondly, it needs pain management. He said, people coming here and suffering. I have had a friend from Kenya telling me how difficult it was for her aunt to go through the urological surgery in a big hospital. She said, excellent facilities, but you don't treat pain. You are cruel. That's what they say. Ria Fernandez says, how to assess pain with decreased consciousness, hypoxic ischemic encephalopathy, etc.
Sir, if I may answer that, we have a few sessions coming up specifically for pain assessment and management.
Yes, precisely what I was about to say, Ria. Maybe we'll postpone answering that question, but in the meantime, Dr. Nithi Rawat has raised hands.
Yeah. Good evening, sir.
Hi,
Sir,
Nithi.
yes, sir. Sir, I just wanted to say one thing, that actually when we are practicing any aspect of palliative medicine and looking into that aspect in a very busy OPD with suppose 80 to 100 patients coming in, even if we want to practice and we want to touch upon something, on the patient, sometimes it's a senior consultant sitting with us and like, telling, why are you wasting time? Just give medications and let him go. So and this is not just like from my experience. Even suppose my father is a cancer patient, so even when I take him, I see that same attitude coming in, although I'm a doctor, from the doctors who are treating him. So like, how do we, what do we do about that?
Dr. Nithi, where are you from, if I may ask you?
Sir, from Bangalore, St. John's Medical
So
College.
maybe it's a very valid question, because when we talk to doctors from General Health Service, they say this water is nonsense. We have to see 120 patients a day. So what, Dr. Nithi, when I am your patient, I will understand if you are very busy. I can see that. I can see the crowd out there. I will not expect you to spend 5 minutes with me. I know that you have only 1 minute to give to me, or 2 minutes. But I'm hoping, Dr. Nithi, within that minute, I hope you will still see the fear in my eyes. I hope even in that busy routine, you will care enough to lay a hand on my hand and say, I am giving you medicines, you will feel better. When your eyes and your voice shows compassion, I'll be reassured. Oh God, Dr. Nidhi Rawat is a human being, being treated by somebody who cares. When you do that, Dr. Nidhi, you have already integrated palliative care into your work. That's the first thing that I'll tell you. We will, another day, I'm sure Sridevi will be having a session on ethics, where we'll talk about the 4 fundamental principles, one of which is distributive justice. If you take compassion on me and give me half an hour, you are being unfair to all the people waiting out there. You can't do that. It's only feeling compassion into the little bit of time that we may actually get. But maybe, Dr. Nethi, you may be, I don't know your situation, maybe you will be able to do one more thing. Maybe out of the 120 patients that you have to see, you will see that one or two people look as if the weight of the whole world is on them. You will see the suffering, and you may say, I see that you are a lot worried. Do you want to get some lunch and come back to me at 2:30 p.m.? I want to talk to you for 10 minutes. Maybe you will be able to reallocate your time so that somebody who needs desperately some time may have it. Because when we do that, sometimes we prevent huge unpleasant consequences, including attempted suicides. We have to do what we can within what we have. Priyanka has a question or comment. Palliative care in the postoperative period, the same thing that I was telling Dr. Nethi, Priyanka. It is not, we don't even have to call it palliative care. When you integrate palliative care into your surgical work, what you do is you treat pain. In our country, surgical pain is usually very, very poorly treated. A patient following an upper abdominal surgery or a thoracotomy without pain relief is a horrible experience. We just treating pain properly, and when you have done that, you have integrated some palliative care into your work. And maybe we might not have time to tell stories, but I actually, as a anesthetic, sorry, somebody was asking a question.
Good evening, sir.
Anubha, we have this problem with your audio. I can't hear you. It is Anubha, isn't it? No, it's Aganksha.
Yes, sir.
Try again.
Good evening, sir.
Good evening.
Sir, I had a question. I wanted to ask, sir, if the physical symptoms have already progressed and the oncologist told that nothing can be done, and along with it, the patient has psychosocial pain also. So as a palliative care physician, sir, then what would be our role? We know that the physical symptoms can also not be managed and the patient is worried because of psychosocial components. So, sir, how can we show empathy at that particular time, at point of time, sir?
Aganksha, your face is already showing empathy. First thing, you allow that. You allow your empathy to come into your face, your eyes, your voice. Physical symptoms may never be, as you very correctly say, may never be completely addressed, like somebody with a terminal bowel cancer with total obstruction will keep vomiting out. There are things you can do about it. You can reduce the frequency and degree of vomiting, but you may not be able to stop it completely. But even there, tell me, you are vomiting, you have pain. Tell me, what else is bothering you? You ask that question, and as Modi suggested, allow a few seconds pause. Give the person time. And then the person may say, I'm worried that my children may have to leave school. Sometimes, Aganksha, there may be nothing you can do about it. But maybe there is something you can do about it. Maybe you will tell your uncle who is a Rotarian, uncle, there is this young woman there who is worried about the children. Is there anything that your club can do? And there may be limits to what you can do. You shouldn't keep kicking yourself because you can't do everything else. I have to keep reminding myself, and Sridevi has to keep reminding herself that we are not God Almighty. There are limits to what we are capable of doing, but we do what we can, and that's important. And I came through the same problem for many years with about mothers and fathers worrying about the children's education, till eventually we set up a program for support for schooling. And I don't have to spend time on it, our volunteers do it. Hey, I have Sridevi is looking still smiling, but at any moment she'll stop smiling because she gave me time till 6 and I've already crossed the time by 9 minutes. Sri.
So we just have one presentation from our side, but if there are any pressing questions, or maybe after that we can take the questions after the case presentation. As it was mentioned in the email, the format will be like an interactive lecture for 45 to 50 minutes, followed by a presentation from your side. So you can, as you have already noticed in the WhatsApp group, you have already sent your names on topics that you would like to discuss. You can bring in a patient story and a template. So today we'll be just doing it from our side so that everyone understands how it works. So I'll present a patient story from our side. Shripriya, next slide. So this is a story of a young male, 13 years old, who had traumatic quadriparesis with stage 4 pressure sore on the sacral region and the left gluteal region. So this is how he reported to us. And when he came, he was constipated for 2 days and he had bed sores over the sacral as well as the gluteal region. There was moderate pain over the hip region and he was complaining of leaking of urine. Next. So he had a fall while carrying weight, followed by neck pain and weakness of both limbs. And he was diagnosed with traumatic quadriparesis in 2015 August. He got admitted in the government hospital, got treated, and then discharged back home after a month. And after 6 months, as Sir was mentioning during his presentation, he ended up being on bed surrounded by 4 walls, and after 6 months he developed bed sores over the sacral as well as gluteal region, and when he came to us it was stage 4 bed sores, and there was a history of pain over the hip and the wound site for more than 2 weeks and pain over the hip region. So we have noticed the pain score in the bracket, which is 5 out of 10 in a numerical rating scale, which we'll be dealing in detail about the pain scores in the coming sessions. And bilaterally he had pain and over the wound side. Due to this, sometimes they keep the wound open so that he's not feeling much of pain. And he had a disturbed sleeping pattern and decreased oral intake. Next. So general examination, he was conscious oriented, temperature, pulse, respiration were all normal. All other systems were also within normal limits. So regarding the pressure sore examination, there was warmth and tenderness. Exudates were present, and while detailed examination, there was tunneling over the in the bed sores. The bed sores were irregular in shape and very, very foul smelling. Next. So routine investigations were also kind of normal. Hemoglobin was 10. I'm not reading it out, but you can see it looks quite okay in the routine investigation. Next slide. So coming to the psychosocial aspects, as I mentioned, he's a 39-year-old young man. He's unmarried, and he was taken care of by his 65-year-old mother in a rented house. He has one sibling, and he's married and living separately, but not caring and helping them. Maybe due to they have their own issues in their family. So he was not in really good rapport with this patient and his mother. He was a manual laborer and was the breadwinner of his family. Now, what happened after the incident? The mother became the manual laborer, and she has to take care of this 39-year-old unmarried man. Now, the main source of income was from mother's daily wages, her pension, and some of his friends used to help him. And they have taken loan, again, as mentioned in the presentation, for the treatment purpose. Even though they were treated in a government hospital, there are a lot of hidden charges that you might understand. So they had to take a loan of 1.5 lakhs for the treatment purpose. He was a Christian, and now he's telling, I'm unable to go to church because I'm kind of bedridden, and that makes him really, really sad. And he communicates through the cell phone to his friends, and he often says to his mother that I don't think I can walk, so it's better that you don't spend money over my treatment, because anyway I'm not going to get up and walk. Next slide. So his main concerns were the pressure sores, the stage 4 pressure sores, as I mentioned, exudative and foul smelling. He had pain, as we have seen before, and the financial issues that he's totally dependent on his mother. who's a manual laborer now, who has to take care of him also. Next slide. So in summary, he's a 39-year-old man with traumatic quadriparesis with bed sores present over the sacral and left gluteal region, stage 4, with pain over the hip region. So for the discussion part of it, we have heard about the concept of palliative care, or the changed concept of palliative care from just the routine cancer care. So do we actually think he comes under the scope of palliative care, as we have heard the lecture? And what would be the problems? We have seen the iceberg now, the tip of the iceberg now. So what would be the problems faced by this patient? And what all can be done for this patient and his mother when you think from a palliative care aspect? How can we care for this particular patient and mother? So these are the points that we would like to discuss in this session. And we would like to hear from you what you think about managing this based on the 1-hour lecture that we have had. Anyone would like to start? Break the ice and start the discussion.
Yeah, hi, good evening here. This is Dr. Bikram from AIIMS Bhubaneswar.
Yes, doctor.
Good evening, sir. Yeah, definitely this patient needs palliative care. There is no doubt about that. And the problems has been discussed in detail by you, Dr. Sridevi, that the patient is a quadriplegic patient, bedridden with bed sores. Is a poor patient, there are financial constraints. So definitely this patient needs palliative care along with other support system from the society and government.
Thank you, Dr. Vikram. Thank you for your comments.
I am Chetty Jose. I am from Kolkata.
Yes, Dr.
Good evening, sir. Here I would like to put the main, like one of the solution we can do is with the help of community engagement. Because I'm also doing some home visits very often here, minimum 10 to 12 patients per month. And the main problem is the community involvement. Like in this sort of case, once you go to the hospital, home, and most of the time your hands are tied up because of you know what to do, but you cannot do. Like most of the one example I will tell you. One patient with breast cancer had pathological fracture. She had pain not because of cancer, with the pathological fracture of arm. But I just wanted, at least we should give some symptomatic treatment to her. For that, what sort of help we can provide? Like, at least I wanted to do some radiological investigation or whatever it is, but I didn't have any facility to take her to hospital and do the further investigations. So in this case, I think local leaders or some politicians or local community people, like they can provide some help with some ambulance or some sort of thing should be there. Otherwise, what we can do?
Yes.
Doctor, sorry. Let me respond to that first comment. Doctor, what's your name?
I'm Shetty, sir. Shetty Jose.
And where do you work?
Also in Kolkata, under Dr. Sangamitra.
Oh, okay.
Yeah, Eastern India Palliative Care.
Okay,
so,
okay.
I joined just the last 1 month. Last 1 month I am with him.
So this is you. There was no question. There's no real reason to answer either. That you have also given the solution. Talk to the neighbors, talk to the corporator, talk to whoever is available. And maybe solutions will emerge. There is more compassion in the community than we ordinarily think. Okay, you talk to 10 people together, only one may do something, but that one is important. Yes, thank you, Shetty.
Thanks, sir.
Thank you, Shetty, and say hello to Sangamitra for me.
Yeah,
okay.
Definitely, sir.
What was the next one? Sorry, I interrupted somebody.
Hi, sir. I'm Dr. Anit from St. John's Medical College. I work in a physical medicine and rehabilitation department. So here we see like a lot of spinal cord injury patients in our department. So I think in this patient, the main problems are like motor is affected. He's having weakness in all 4 limbs and sensation is affected. That's why he's presenting with a pressure ulcer. And he's having a neurogenic bladder. Also, there is a history of constipation. There is a neurogenic bubble also which is involved. And pain is also a main complaint. So since there is pain, usually patients present with like pressure ulcer when there is no sensation. Here patient is complaining of pain. It could be, I think, either neuropathic pain, which he is complaining, or if the patient may be an incomplete spinal cord injury. In that case, I hope the patient will have some partial powers in his upper limb and also in lower limb. So from my definitely patient needs palliative care, and but from my I think I would like to put it in another way, we need to integrate palliative care into rehabilitating the patient because he have a lot of potential. First thing we need to address there is he presented with like lot of infection, his counts was high. We need to treat the infection. We need maybe the debridement is needed, and there can be a flap surgery which can be done if it is possible and affordable. Otherwise, lot of other methods are there to address the pressure ulcer. And if there is, I think if there is like power in the upper limb, we can train patient for some basic ADLs. He don't have to depend on his caretaker for like activities, even like a brushing, combing hair, or feeding himself and all. And I think bladder and bowel also need to be a proper program, bowel program and bladder program for management of the neurogenic bowel and bladder. And I think the hip pain there could be like an underlying heterotopic ossification, which is commonly seen in spinal cord injury. So if the patient has referred to rehabilitation along with palliative care also, I think the patient have a good potential and he can be a breadwinner again for the family too. We can refer him to like associations which deals with disability and all.
Thank you, Dr. Anit, for that wonderful.
Dr. Anit,
all the
may your driving grace. Yes, indeed. Physical medicine department has such a huge role to play in palliative care, and every word that you said is important. And I hope you come and visit us, Dr. Anit. We do have a few physiotherapists, and we have a physical medicine specialist giving us 1 day a week to visiting people's homes and teaching the families. So we are more than aware of the value of physical medicine and rehabilitation. And even if he doesn't earn enough for the family, imagine if he makes 20 rupees a day, how much self-respect will increase. He who was thinking that I am a burden to everybody is going to get a lot of pride in his existence with that. Thank you. Sorry, somebody else has a raised hand. I suppose you can stop the screen share.
Yes,
so that
yes.
we can see one another better.
So my question was, considering the entire scenario, it looks like he has a lot of psychosocial, all the emotional concerns that he doesn't want money to be spent on treatment, etc. So what would be the ideal sequence of care for this patient? Do we first, in this situation, address the physical symptoms, or do we start with understanding what his emotional concerns are and then going ahead with the treatments?
Sweta, thank you. You remember the iceberg?
Yes.
What is visible, what is in the surface has to be treated then and there. And then you go into problems. And Sweta, one more thing we'll remember is we may not be able to solve all the problems. I'll remind you, Shweta is not God Almighty. There are limits to what we can do, and we have to accept that, or we'll find ourselves willfully turning away from suffering. So when somebody says, Mom, don't spend money on me anymore, there's no point. Shweta, do you hear hopelessness in his words? He has lost hope.
Yes.
Life is difficult when there is no hope. What do? One, of course, you give him love and compassion. Make him feel that the world is not as uncaring as he thinks totally. Secondly, in our conversations, set some achievable targets. Maybe very small thing. Maybe hanging something above his head for him to pull himself up. Something to improve, and one achievement may give him hope of one more. You set small targets, achievable targets. and try to improve. By caring for the person and trying to improve the quality of life, however little that may be, you are making enormous difference.
Thank you, Dr. Shweta. I think Dr. Mirazan has raised his hand.
Actually, when I get my answers, hi, I am Dr. Miraju from Paternet Hospital. I want
Where are you from?
From Silchar, Assam.
Okay.
Yes.
Are you from Catcher Cancer Center?
Yes, sir.
Oh, I see. Okay, welcome.
Sir, I am here looking for the patient of financial aspects of this patient. Is there so that is my point of concern in that we should take.
Rasul, can you please speak up a little bit? You were beginning to talk about the financial aspect and then you said something else which I did not get.
Hello. Hello.
Somebody needs to mute your microphone. Yes, Dr. Marasu.
Sir, we should take a look at the financial aspect of this patient because there is a lot of problem in the mother's level is so that should be the triggered point of this pain also.
Absolutely. Totally, Rasul. Long back, when I came to visit your center, your director, Dr. Padmasri Devikannan, told me a story. He told me about a family where the woman was having cancer and her main concern was about having sold her son. The family was so poor that they had given one of their children away for a measly 6,000 rupees to bonded labor. And this is our country. These are the realities in our country. And the director of the cancer center, in addition to treating the person with chemotherapy and radiation, also had to find the money and do the negotiations to get the child released. Yes, we'll look at it. And for that, who was it that earlier told us, Shweta, that the community, or sorry, if it is somebody else, the community needs to be engaged because by ourselves, our abilities will be limited. Thank you, Dr. Marasul, for pointing that out.
Dr. Nishant, you want to talk something?
Hi, sir. This is Dr. Nishant again from Kachar Cancer Hospital, sir.
Oh,
okay, Nishant. I'm a radiation oncologist here, sir.
Okay.
So we do home visits here, and we go to tea gardens, and tea gardens and workers are the major patients here, actually, because the habit of chewing and use of tobacco, and these are the patients who end up with head and neck cancers, and we treat them here. So, sir, during the treatment, invariably, these are the patients which we have to put on dialysis tube because of head and neck cancer and the nutritional issues. So, during the treatment times, sir, we do provide them nutrition. But after that, when we go to the home for the home visits, the complaint is that although they have gone through the treatment and now they are off the dialysis tube, but they don't know what to eat because they have not been able to swallow for so long. So, for the same reason, we are doing swallow clinics, sir. But again, the common complaint is that they were happier earlier and they would have died peacefully rather than being dependent on the rice tube for 3 months, and then after that when we have removed the rice tube, the complaint that they're not able to eat, or there are oral ulcers for a longer duration, so that becomes a concern, sir. I don't know how to palliate them in a community setting wherein the resources are very limited. So that is one of the things that I would want to add here.
Dr. Nishant, thank you. I did not quite understand. So they have been on an esogastric tube during the period of treatment. Then the tube comes out and they are not able to eat because of oral ulcers.
They're not able to eat because of oral ulcers, or probably even if they have the rice tube on, they're not really they're not easily able to afford the kind of food, or they're not educated enough to put the kind of food that is necessary in the rice tube. Or maybe we have removed the rice tube, but there are ulcers that they're not able to manage.
I see your point. I mean, like it's like the suicide prevention programs. You prevent stop somebody from killing themselves and leave them to a fate that to them is worse than death. What's the point? You have to continue care. I'm not saying that you shouldn't save people from suicide, but the care should not stop there. Now, there are limitations, Nishant, to what we can do, but within our capability, our aim is to get them to a state of improvement enough so that they are able to swallow. But maybe if the oral ulcers are so bad, maybe the nasogastric tube needs to go back for 2 more weeks. But I see the problem. They may not be able to come back for admission. In the village, it's very traumatizing for you also when you say, I wish you had not treated me. I would have died and I would have not been as miserable as this. But I also have had the experience of somebody saying, okay, you say, eat this, you say, eat that, I have no food. So these are the realities in our country. Nishant, thank you. I am not here with all the solutions, but I hope together we'll find some of the solutions for the social issues. And it is easy to be discouraged by too many problems, but then experience teaches us that every little bit counts, and by changing your own life for the better, you are making the world a better place. Dr. Aditi, you have a question.
Yes, sir. Good evening, everybody. With regards to the just case that discussed previously by Dr. Nishan, I'm actually a family physician, and I do a lot of home visits for who are terminally ill or bedridden patients. So one of my patients is a case of supranuclear palsy, and he's right now can't speak and has quadriplegia as well. The patient's family, they're quite affording, and that is the financial part is not the issue, but they deny for Ryle's tube, and he has repeated incidences of aspirations as well. So what could be done? Do we respect the family and the patient's opinion that no, they don't want a Ryle's tube, or but having repeated aspirations and getting their health down, what should be the idea about it?
Aditi, I am your patient. I am fully conscious. Who should be taking decisions? Autonomy. Yes. This is my life.
Yes, definitely.
You have 6 degrees, but this is my life. So the first thing is, am I fully competent to take my decision, or am I delirious? If I am not, if I am competent, you sit down with me and find out why I am saying that. Maybe I am saying that the last time you put that thing in, it was such a horrible experience that I don't want to go through that again. I'm willing to die. There may be situations, Aditi, where you will have to say, I've tried my best. This is the best I can do. It may be all that you can do. And I have learned to accept that kind of thing. But I also know the value of finding out, okay, last time, tell me, what exactly did you go through? And they may say, I could feel this thing pressing on this corner. And it was so painful every time I even swallowed saliva. Maybe there was a coiled up nasogastric tube irritating part of the process. Who knows? It's about going into the details, finding out exactly why. Why are you saying that? And doing what we can. But I would still respect autonomy. And you know, Aditi, that even if you don't want to respect autonomy, you can't force a nasogastric tube on that person. He'll pull it out. Of
no,
course.
respecting that, but sir, he does have repeated aspirations a lot. So that
yes, Aditi, I quite see that, and we all have to live with this painful thing. We know there is a solution, but the patient doesn't accept the solution. You have a curable cancer, easily curable cancer. The person goes away and goes for some goes to some quack. We have to just simply watch that happening because we are powerless beyond a certain limit. As I said the other day, we have to learn to live with some things, try our best, and that's all.
Thank you so much.
Thank you. I think we have overshot 4 minutes.
Oh, Sri, 4 minutes past time. Almost criminal.
Yes. So, if there are more questions, please send us through the WhatsApp group or email us. Then we'll get back to you with the answers for sure. And thank you so much for the wonderful interactions. And for Dr. Aditi, we have more sessions. I mean, one more session on medical ethics where we'll be giving real life scenarios and have discussions based on that. So hopefully we'll be discussing this in much detail about during that session. Thank you so much everyone for the wonderful interaction and the questions and your comments, and thank you so much sir for the good introductory session that you did. Thank you so much.
Thank you everybody. Nice to see you
Yes,
all.
sir. It was really nice listening to all of this.
Thank you, sir. Thank you, sir.
Thank you, everyone.
Thank you, sir. It was good to see your smiles. Sorry, Sri. I'll shut up now.
Thank you, sir. Oh, sir. Thank you, Dr. Rajagopal, for joining us. We do understand your busy schedules and you found out so much time for this cohort. Thank you so much. We are the fortunate lot. And thank you, everyone, for joining us. And we have just started our journey. So please be with us. Let us together make this world a better place to live for the sufferings. So with that note, this is Sri Priya along with Dr. Rajagopal and Dr. Sridevi Warrior signing off from the Tips Echo desk. See you in the next session with another interesting topic and another faculty. Till then, everyone, stay safe, be safe.
Thank you.
Thank you, sir.